We must approach this with scientific restraint, and the trial reports are very clear about the hurdles.
Okay, what are they?
First is the issue of durability. The success stories we just discussed have follow-up periods of 1 to 3 years.
Which is incredible, but it's not a lifetime.
Exactly. We simply do not know the functional decay curve of these lab-engineered cells inside the complex human body over a decade or two.
Right.
Will these cells exhaust themselves in 5 or 10 years, requiring patients to undergo secondary booster transplants? We just don't have the longitudinal data yet to answer that. Second is the risk of oncogenicity.
The cancer risk.
Specifically, the risk of teratomas. Because pluripotent stem cells have the power to become absolutely any cell in the human body, they are inherently volatile.
That makes sense.
If even a microscopic fraction of undifferentiated cells that haven't fully committed to becoming islet cells accidentally make it into the final implant, they don't know what to be. So they could theoretically grow infinitely and form highly dangerous tumors composed of random tissue types. The chemical purification processes in these labs are incredibly strict to prevent this, but it remains a primary fear for regulatory bodies worldwide. And third is the sheer economic friction of the process itself.
Cost.
Custom growing a bespoke batch of autologous stem cells for months in a highly controlled lab is immensely labor-intensive. It is not currently something that can be mass-produced on a standardized assembly line.
Which makes it incredibly expensive. But I want to push back on something regarding the type 1 patients specifically. Hold on. If type 1 is fundamentally an autoimmune disease, it means the body's immune system is explicitly programmed to hunt down and kill insulin-producing beta cells.
That's correct.
So taking fat, turning it into new beta cells, and putting it back in doesn't fix the underlying immune system glitch. Isn't that like putting a brand new engine into a car where the car's computer is still explicitly programmed to destroy the engine?
That is an exceptionally accurate analogy. The autoimmune memory is arguably the fatal flaw in treating type 1 diabetes, even with a patient's own autologous cells. The patient's body won't reject the cells as foreign, but their existing autoantibodies, the ones that cause the diabetes in the first place, might eventually recognize them as beta cells and attack them all over again once the initial honeymoon period of the transplant ends.
So how do you stop the new engine from being destroyed by the car's own computer?